Halamati Habibu, Halamati Habibandale, Halamati Habibu, Halamati Habibanda, Halamati Habibu, Halamati Habibandale, Halamati Habibu, Halamati Habibu.
once is depleted, the patient goes into a state of fasting where lactate, alanine and he come back so that the access to food is present when you are advising the meals, and when and what place the patient takes the insulin. So sometimes the patients are find it difficult to take insulin in public places like maybe in the class, etc. So sometimes they may be skipping insulin at that time. You have to adjust a time when they can take the insulin and take the meal also, because if you take, okay, sir, I will take 5 minutes. Sir. So we have to take the example of a class 8 school boy who wakes up at 6 a.m., leaves for school at 8 a.m. So this is his routine. But and this is his diet. He takes the breakfast, lunch, tea, dinner, etc. But suppose he was diagnosed to have type 1 diabetes at this stage. So now what is new in his life is he has to take insulin, and it would be basal plus bolus in the morning, bolus at the lunch, bolus insulin before dinner, and a basal insulin at in the night also. So according to that, there should be dietary modification, that the patient should have an early tea to avoid a fasting which was started in the last night. So early tea should be given. A split breakfast should be advised, that whatever you are taking 3 chapatis in the morning, you make it 2 at 8 a.m. and 1 at 10 p.m. A split breakfast should be advised. Lunch should be there, and it should be a low glycemic index lunch, and there may be an after school snack. A low glycemic index dinner and a bedtime snack are advised. But for a 40-year-old obese female, you need not give so much of snacks in between, because it will only add to the calories. You can just, suppose the patient is not on insulin, you can just decrease the calories in all ways possible. You may not need to give the snacks in between. fruits, and don't take it with the meals. Take it sometime away from the meals so that at least it will help in decreasing the risk of hypoglycemia. Now, what is glycemic index? Glycemic index is the increase in blood sugar levels which are caused by a certain amount of food. So, if you take in sugar, it will cause a rapid rise of blood sugars, whereas if you are taking the same amount of carbohydrate mixed with some other fiber rich food, it will not increase the blood sugar levels in at the same level. Dietary fiber, we cannot go into the details. Now, how much to eat? So, you have a patient in front of you, 50 kg, who is 150 centimeter height. So, the patient is having an ideal body weight for her height. For such a patient, you can advise 30 kilocalorie per ideal for the body weight. But if the patient is overweight or obese, you have to decrease the calorie per kg, and you can advise 25 kilocalorie per kg for the overweight and 20 kilocalorie per kg for the obese patient. And it should be adjusted for physical activity. Someone who goes for exercise, you have to increase the kilocalorie, and certainly for those who are having a heavy activity, you have to increase it further. And you have to keep in mind the nutritional needs for children, pregnancy, etc. Now, this is a standard 1500 kilocalorie which we had prepared. Now, coming to the injection practices, injection storage, insulin should be stored, just keep in mind, less than 25 degrees Celsius in most occasions. It will go for up to 1 month, and if you are requiring to keep the insulin for more than 1 month, that is, it is bought for next 3 or 4 months, you have to always use the fridge, or it should be stored in the door of the fridge where the temperature is maintained between 4 and 8 degrees Celsius. Frozen, if you find that the insulin has got frozen, it should be discarded. It is of no use after that. But the pens, sometimes everybody will tell you that you can keep it at room temperature, but frequently in our place the temperature goes above 25 degrees Celsius. So it is preferable that you store it in fridge and you put the insulin out of the fridge 10 minutes before injecting, and after that you can take. So why you are keeping it out? Because the cold insulin can cause pain and irritation at the local site. Device selection and use, we should know that there are two types of syringes, the U100 syringe and U40 syringe. The U100 syringe should be used with the U100 insulin, and vice versa. The U100 syringes have an orange cover and a black scale markings, whereas the U40 syringes have a red cover and a red scale markings. The injection sites are very important. Never advise a patient to take on the deltoid by self, because 2 hands are required for injection. You cannot inject it with the one hand because there is a high risk of going it in intramuscular. And best site for taking the regular insulin is the abdomen. And how you advise, I will just see. What I do is, we advise them to take at least 4 finger breadths away from the umbilicus on one side. You go in a clockwise manner, and once you have pricked it 7 times, you go to or for 1 week you can do on the right side, and for the next week you can go on the left side, and at least 2 centimeter gap should be given from the injection which was taken yesterday. And you should avoid the midline, because the blood flow to the midline is less, and the umbilical region, there can be a certain risk of uncleanness, infection, etc. can also be there. And so whenever we are giving, the insulin taken at the abdomen is absorbed faster, whereas taken at the thighs is absorbed a little slower. And also the thing is that once you have taken the insulin on the thighs, it is advisable not to go for heavy exercise after that, because it can enhance the speed of absorption. And so these are the sites where you can take. Then the 7-step site care process, the site should be clean, or it should be cleansed before injection. The patient should be advised to palpate for lipohypertrophy. At least we should know how to palpate for lipohypertrophy using at least 4 fingers we should run it on the place where the patient is taking the insulin. You will find that a little firmness in the soft region of the abdomen. How you can avoid it by it is by rotating the injection site systematically, and ideally it is said that you should not reuse the needles, but in Indians what it is advised is that you should not go for reuse for more than 4 injections. And you can see this is visible hypertrophy, but mostly it is not visible, it is only palpable. So here we can see. And now coming to the other phenomenon which can cause poor glycemic control, we should know the dawn phenomenon. It is just due to the insulin action is not reaching the next day morning, that it has the sugar levels remained normal till 3 a.m. or 4 a.m. and suddenly it has shot up in the morning. So that is called the dawn phenomenon. Whereas the Somogy phenomenon is different. There is a hypoglycemia, which is like a spring action. If the sugar levels go very low, there will be an equal and opposite reaction, or not equal. There will be a opposite reaction to increase the blood sugar levels for the next 48 hours. There will be increased levels of hormones in the blood, which will cause a rise. And this can occur at around 12 midnight, or it can occur at around 3 a.m. or 4 a.m. in the morning. The one occurring around 12 midnight is due to the shorter acting insulin which has been injected at night, whereas which is happening at the 3 a.m. or 4 a.m. is due to the longer acting, or the NPH insulin is typical to cause that in the morning. So for the dawn phenomenon, you can use a higher dose of basal insulin or a longer acting insulin, whereas for the Somogy phenomenon, you have to decrease the night dose of the basal or bolus insulin, which has caused the increased blood sugar levels. And blood sugar monitoring is very important. The charting should be done always in relation to meals. It should not be done in a random fashion, that 2-hourly blood sugar, 4th-hourly blood sugar. This is actually not indicated in any patient who is taking orally. So any patient who is taking orally, you should always go for sugar testing only in relation to meal. The blood glucose charting, so this will give you an idea which insulin you have to adjust. PPBS is controlled by the prandial insulin which you have taken before the meals, and the pre-meals or at least the fasting is controlled with the basal insulin. So now you can see this is a patient who was once you cannot control the blood sugars in the as an OP, you can go for an IP evaluation, and if the patient is admitted, you can see the fasting is high, PPBS is high. These were the doses which were going. First what we do is we continue the dose for 1 day what the patient was taking, and N indicates, NPHR indicates the rapid acting insulin or regular insulin. Now what we see is that we start correcting the blood sugar levels with some correction doses, and to correct the fasting blood glucose levels, we increase the NPH, and to correct the postprandial levels, you increase the regular insulin doses. And slowly, by increasing the doses one by one, you can achieve a good glycemic control. And whatever correctional insulin doses have been given on 1 day should be added to the preprandial doses on the next day. Now, regarding hypoglycemia, there should be an advice to the patient how to control hypoglycemia, how to find it out. The symptoms are there. Then suppose the patient experiences a hypoglycemia, he should take at least 15 to 30 grams of glucose, so that the patient can recover fast, and the patient should have a retest of blood sugar levels at 15 minutes after that, and ensure that after 10 minutes that it has crossed 100 milligram per deciliter. Now, how to combat severe insulin resistance, which is another problem. You should always recheck exercise, help the patient build up muscle, weight loss by all means, and control hypertriglyceridemia. Look for hypertriglyceridemia. If it is there, if you control hypertriglyceridemia, you can achieve a better glycemic control. Consider non-insulin mediated medications like metformin, gliptins, SGLT2 inhibitors, and GLP-1 analogs. Then bariatric surgery in patients who are having severe obesity and indications for the bariatric surgery. With that, I end the presentation. I'm sorry for being a bit late, but the topic was
Absolutely no problem. Thank you, Dr. Abhilash. The floor is, the talk is open for discussion. If there are any questions?
So I have just mentioned all the process. Now, if there are questions, we can have a discussion.
Any questions from the floor?
Yeah, please. Gliptins.
Long-standing internal diabetes, say some 20 years old.
Yeah. So, if the patient is, there is no problem with indication that we can give given, but the effectiveness, how much effective it would be, because gliptins gliptins increase the GLP-1 levels in the blood or maintain the GLP-1 levels in the blood. They have two types of action. One is increasing the meal-related insulin secretion. Second is a small effect on satiety, gastric emptying, etc. So even if the insulin levels are not increased with these gliptins, you can have the other effects. Although we don't know what is the relative contribution from each of these effects, we can use.
I think there are no more questions. We will wind up this session. Thank you, Dr. Abhilash, for making a difficult. Sorry.
Dawn phenomenon and somnolence that are seen at midnight, at 12 a.m. and 3 p.m. It is very difficult to measure blood glucose at that time. So, it is possible to know the problems of these phenomena by means of measuring blood glucose as FPS.
By FPS, both of them will give you a high FPS only, ma'am. So if it is difficult to check it in the morning, if it is only due to the problem of waking up, you can go for a continuous glucose monitoring system, which will cost you around 1,800 rupees for a patient for getting the values for next 7 days. You can have multiple values, and it is only by measuring we can say that whether it is dawn or Somogia phenomenon. Then second thing is what you can do is to avoid the Somogia phenomenon. You can always advise that the patient has to take a bedtime snack before sleeping, so that at least the 12 p.m. 12 midnight hypoglycemia can be avoided. So at least one part we can correct, and only by FPS we cannot say that whether it is dawn or Somogia.
Sir, in one of your slides, you are showing that insulin syringe 1 division is 1 unit, and I think the second one, tuberculin syringe 1 division is equivalent to 2.5 units. It was 2 units in the slide.
It was
2 units in the slide. I think it is 2.5 units.
I didn't get the question, but on the insulin syringe it is marked as 0 to 40 itself.
I think you can ask Dr. Abhilash difficult questions from later part of the day. Thank you, Dr. Abhilash, and let's wind up the session for more to come. Thank you.
Thank you, sir, for the informative section. Now, I request the chairperson, Dr. Srikanth K. and Dr. Anil Vijaykumar to hand over the memento and certificate to Dr. Abhilash Nayak. Thank you. Now, I invite our respected faculty, Dr. Pramodini ma'am, HOD of Department of Biochemistry, to hand over the memento and certificate to the chairpersons.
The obesity pandemic is driving the increased prevalence of type 2 diabetes mellitus, and a vast majority of patients with type 2 diabetes mellitus are either overweight or obese. Excess body weight is associated with the risk of cardiometabolic complications, which are the major cause of morbidity and mortality in type 2 diabetes mellitus. We now proceed to the second session. This session is chaired by Dr. Rajashekharan C., Professor, Department of General Medicine, Azizia Medical College, and Dr. Jayesh, Consultant Vascular Surgeon, Azizia. With all due respect, I now call upon Dr. Tony P. Joseph, Consultant Endocrinologist, Home on India and GG Hospital, Trivandrum, for addressing the topic titled Weight, the Unaddressed Foe in Diabetes. We welcome you, sir.
Welcoming Dr. Tony Joseph, sir, for his talk on weight and unaddressed foe in diabetes.
Weight is really a big problem when it comes to treating diabetic patients. When the scores of patients which you see in our practice, the biggest hassle in convincing that they are overweight. So I think this is prudent to choose a topic like this by Tony. Tony is from Trinity College. He passed his MD in 2012.
15.
2015.
12 to 15.
And he had DM in endocrinology from Sanjay Gandhi Institute of Medical Sciences, Lucknow. I am very glad that Tony was a brilliant student. In fact, we had published a couple of papers also, is it not?
Yes.
So welcome Tony. Dr. Tony, please.
So thank you, thank you Rajshekharan sir. Thank you to the organizers for having me here. So as sir said, weight is usually an unaddressed issue that we usually face in our diabetes management. Most of the people with diabetes who come to our OPD are either overweight or obese. And we have to know that the cutoffs for overweight and obese are lower in our population compared to the Western counterparts. So we have a cutoff of 23 to 24.9 for overweight and more than 25 for obesity. And most of the time if you see at least 90% of your diabetes patients will be either overweight or most of them will be obese. And what are we doing to manage this? So this is how I'll be taking forward the talk. I'll be talking about the benefits of weight loss as a means for treatment of diabetes and in some selected cases diabetes reversal. The main studies, the counterpoint, the counterbalance and the direct studies and how it has impacted or changed our clinical practice, and some new concepts about the twin cycle theory and the beta cell differentiation and the current treatment options that we have. So there is a growing appreciation that obesity is a chronic condition and is caused by multiple factors, behavioral, genetic and environment, to name a few. So adipose tissue is not an inert tissue, it is an endocrine organ. It releases and responds to various hormones that contribute to metabolic diseases like diabetes. In 2013, the American Medical Association has designated obesity as a chronic disease. And more than 90% of patients with type 2 diabetes have a BMI more than 25 kg per meter square. This is Western data. So obesity, it affects all the organ system just like diabetes and causes increased rates of cardiovascular disease, renal disease, cancers, arthritis, sleep apnea, etc. So any degree of weight loss is beneficial for a person with diabetes. And also any person with obesity, they will benefit from weight loss. So it is seen that at least 5 to 10% of weight loss, it results in reduction in the risk of diabetes in those who have a family history or have a genetic risk of diabetes. It reduces the progression from pre-diabetes to diabetes. If you have a significant weight loss of maybe at least 10 to 15%, you might be able to induce remission in people with diabetes. Not just diabetes, all the other risk factors like the lipids, the blood pressures, the cardiovascular mortality, all these come down significantly with at least 5 to 10% weight loss. So the UKPDS has shown us that by the time you develop diabetes, the patient is believed to have lost 50% of his beta cells. And these studies, this UKPDS occurred in a group of patients when you had the older medications, the metformin, sulfonylureas and insulin, where these patients experienced weight gain. So these patients on an average had a weight gain of 5 kgs. And the beta cell loss, which was believed was established by the insulin immunostaining of the pancreas. And now we have the newer concept that these beta cells are not lost, but actually they go into a state of de-differentiation. That is why you are able to reverse diabetes or at least control diabetes to some extent with weight loss. So the benefits of bariatric surgery were believed to be because of increase in the incretin hormones. But fasting plasma glucose reduction was seen in the initial weeks itself after the bariatric surgery, especially the biliopancreatic diversion. And these changes occurred even before the patient had clinically meaningful weight loss. So the potential role for negative energy balance or decreased calorie intake was postulated in these patients. We know that after bariatric surgery, for the initial few weeks, the patient is kept on a fluid diet. They are gradually reintroduced on semi-solid diets to solid diets. So it was during this phase itself that, in the initial phase itself, it was seen that patients had an improvement in their blood sugars. So again, the another concept that we had was the resistance. The insulin resistance was mainly occurring at the muscle level. The glucose disposal by the muscle was reduced. But in the last few decades, we know that the liver also contributes to the insulin resistance. The liver fat increases the insulin resistance, it increases the fasting hyperglycemia. So taking all this together, the counterpoint study was made by the authors, mainly Roy Taylor et al. So here they wanted to see the effect of acute calorie loss on the remission of diabetes, on weight loss and the remission of diabetes. So this is the counterpoint study. So here they enrolled very few number of patients, 11 patients to be exact, and they instituted them with a very low calorie diet, around 600 calories of diet for around 8 weeks. So this was one of the first studies which showed that diabetes was, type 2 diabetes was reversible. Up to then, up to 2011 till the study came out, it was believed that diabetes is a chronic progressive disease. But at least in a few selected patients, as in this study, it was seen that diabetes can be reversed. In this study, there was almost 10% reduction in the hepatic fat. There was a reduction in the pancreatic fat to the tune of around 2%, and there was a decrease in the toxic intermediaries, mainly the diacylglycerol, the free fatty acids, etc. So accordingly, the twin cycle hypothesis came into play. So what is the twin cycle hypothesis? So basically, when you are taking in more calories than what you want, so there is a positive calorie balance. So when there is a positive calorie balance, the body deposits these calories in the form of fat. So there is de novo lipogenesis which is occurring in the presence of insulin. And there is initial deposition of this fat inside the liver. The deposition of fat inside the liver, this leads on to further resistance inside the liver, leading on to decreased insulin suppression of glucose production. So insulin is not able to suppress your basal glucose production from the liver or gluconeogenesis. This results in increased in the blood glucose, the hepatic glucose output, fasting hyperglycemia, and in turn leads to increase in the basal insulin secretion. So when there is increase in the basal insulin secretion and you have increased calorie intake, again the liver fat is increasing. So this cycle keeps on turning. And then what happens is that when you have more liver fat, the liver is exporting out triglycerides in the form of VLDL triglycerides, and this gets deposited in the ectopic sites. It can be deposited in any visceral organ, and one of the sites is the pancreatic islet cells. So deposition of this fat inside the pancreatic islet cells, this leads on to decreased insulin response to a glucose trigger. subsequently the pancreas starts acting more, it secretes more insulin, but after a particular phase, the pancreas also is actually it's stunned, it goes into a state of de-differentiation, where the acute glycemic stress, the acute lipotoxicity, this leads the cells to go into an inert state. So I'll be discussing that in the subsequent slides, and this results in postprandial hyperglycemia, and again contributes to the increased glucose, and increased glucose again gets deposited in the presence of insulin inside your fats, inside your liver, and this cycle continues, the liver cycle and the pancreatic cycle. So this is one of the new concepts that have come in the last few years. Previously it was thought that, just like the UKPDS study, that beta cells are depleted by the time you are developing diabetes. But actually what is happening is they are going into a de-differentiated state at least earlier on in the course of diabetes. That is why you are able to reverse diabetes. So when a normal beta cell is given a stressful stimuli, whatever be it, then it secretes more insulin, as you see on the left hand side. But like I said, in the earlier hypothesis or the earlier theory, it was believed that after a particular period of stress, they go into a dysfunctional state and they eventually result in apoptosis. But this is not the case, at least initially in the period of type 2 diabetes. So the new hypothesis is that they go into a de-differentiated state. So this is the normal development of the pancreatic beta cells. You have the stem cells, the definitive endodermal cells, the multipotent cells which get differentiated to ductal cells or acina cells, which form the exocrine pancreas, and then you have the pre-endocrine cells which get differentiated into the beta cells, alpha cells and delta cells. So one thing to note is that the pre-endocrine cells are the precursor cells from where all the islet cells are developed. So once you are giving the pancreas some toxic stimuli or glucotoxicity or lipotoxicity, whatever be it, these cells, they get reverted back to their precursor state, or they can trans-differentiate into an alpha cell or a delta cell. And this is bidirectional. When you are taking away the stimuli, the cells can go back to their differentiated state. So this formed the basis of diabetes reversal studies, many of the diabetes reversal studies. And after the counterpoint study, if you see, the people with diabetes, they were very excited about this study. They started writing letters to the authors about what type of diet they were using to reverse diabetes. And eventually these authors, they published their diet, and people started taking this diet either by themselves or with the help of dietitians. So what happened is many people who took this low calorie diet of 600 to 700 calories, they started experiencing significant weight loss, and 60% of them experienced remission of diabetes. So more the weight loss, more the diabetes, and more the diabetes remission, and more the less the duration of diabetes, more was the chance of remission. So this study again was published by these authors on the basis of emails, letters and telephone communication that they got from the participants. These were not recruited participants, these were people who who enrolled by themselves into the study, those who wanted diabetes reversal. So we know that our any patient who is coming to our OPD also, they first ask us what is the cure for diabetes. So people do all type of things to like reverse diabetes or be diabetes free. So this was a very important study in that you see that people itself, the participants itself, they initiated this low calorie diet, and they were able to go into remission of diabetes. So subsequently the counterbalance study came into, the counterbalance study was initiated. So counterbalance study was basically to see whether this acute calorie loss and acute weight loss, which resulted in diabetes remission, whether it was sustainable in the long run. So after an 8 weeks of low calorie diet and weight loss, these patients were monitored for around 6 months. And it was seen that in this study, there was 30 patients, they lost on an average 15 kgs of weight, and 12 of the 30 patients, that is around 40%, they entered remission, and this remission was sustained even at the end of 6 months. So if you see here the low calorie diet, it resulted in a meaningful weight loss by around 8 weeks, and following this the patients were put on an isocaloric diet and they were advised to exercise. The weight was maintained, and you see that the A1C reduction, this was also maintained. So the lower one is the people with who had entered remission, and the upper one, the bar is for the people who did not enter remission. So the main characteristic of those who entered remission were a short duration of diabetes, a high insulin level or a C-peptide level at the entry into the study. So this led to the next study, the direct study. So this was different from the previous studies in that it was a primary care-led study, where the people who instituted the weight loss were either nurses or dietitians. So in this study, again, patients lost weight, but not to the tune that was lost in the previous studies. So patients who lost more than 15 kg weight over a period of 12 months, they were 24% in the intervention group compared to the control group. And if you see the proportion of patients who are achieving remission of diabetes, it was almost 50% in the intervention group compared to 4% in the control group. So another thing that you see here is that depending on the degree of weight loss, the remission also improves. The chance of remission of diabetes also improves. So with less than 5% weight loss, there was around 7% of patients who entered remission, and when the weight loss increased to more than 15 kgs, the remission was 86%. So with this study, they also showed that the metabolic risk factors like dyslipidemia, hypertension, the obstructive sleep apnea, all these significantly improved in the study population, and their quality of life also significantly improved. So previously, when we were managing diabetes, even up to a few years back, we followed a glucose-centric approach. We were down here in the ladder where we just targeted the glycemia. By controlling the glycemia, we were able to reduce the microvascular complications and to some extent the macrovascular complications. But what about the other risk factors? The dyslipidemia, the hypertension, the people who are having NASH or CAD, they are also at an increased risk of macrovascular complications like CAD. So this to some extent can be addressed by addressing the weight or adiposity. So now from a glucose-centric approach or a downstream approach, we have moved up to a more comprehensive approach, a more weight-centric approach, or an upstream approach where you are targeting all the risk factors which lead on to macrovascular and microvascular complications. So are the benefits of weight loss or calorie restriction are the benefits of calorie restriction evident only on weight loss? So this was a group of patients who are having metabolic syndrome. So we know that metabolic syndrome consists of 5 parameters. You have to have at least 3 of these: increased waist circumference, fasting blood sugar more than 100, HDL less than 40 in males, less than 50 in ladies, the triglyceride more than 150, and BP more than 130 by 85. Any three of these 5, you classify the patient as having metabolic syndrome. So people with diabetes, at least 90% of them have metabolic syndrome. So if you see in these patients with metabolic syndrome who did not lose weight on a low calorie diet, there was still improvement in glucose, the blood pressure, the lipid levels, and also the atherogenic lipid profile also improved from a small dense LDL particle to the larger LDL particles, and the saturated fats also improved. So benefits are not just benefits of a low calorie diet is not just because of weight loss. It is also independent to some extent of weight loss. So what are the current treatment strategies that we have to manage people with diabetes and obesity? So any person who is coming to our OPD, take a BMI, take a height, weight, calculate the BMI. If the patient is overweight, that is more than 23, or obese, more than 25 kg per meter square, advise them on lifestyle modification. The the recommended weight loss is at least 5%, and any weight loss more than that will give you additional benefits, not just with respect to glycemic control, with respect to other risk factors also. The diabetes prevention program, this was done in patients who are having pre-diabetes, and when they were instituted an intensive lifestyle modification and they lost 7% of their body weight, they were able to prevent the progression of from pre-diabetes to diabetes by around 60%. This was when compared to 30% in the metformin users. So when you have associated comorbid conditions in your people with diabetes, when your patients with diabetes like depression or some other autoimmune disorders where you're using antidepressants or steroids, you always try to reduce medications which can result in weight loss or use medications which are weight neutral. So all the FDA approved drugs for weight loss has been shown to improve the glycemic control also in people with diabetes and delay the progression of type 2 diabetes. So this is just in short about the pharmacological treatment from the ADA 2022. So here again they emphasize, in addition to a patient-centric approach, always lifestyle modification is emphasized here, and then the drug which should be added depends on the patient characteristic. If the patient is having ASCVD or high risk factors for ASCVD, CKD or heart failure, you institute either SGLT2 or GLP-1 RAs. If the patient is not having these high risk features, then again you want to minimize hypoglycemia, or in overweight or obese patients you want to promote weight loss. So in these situation also you use drugs like GLP-1 RAs or SGLT2 inhibitors which have modest weight losing effect. So lifestyle modification has already been discussed by Abhilash sir. He has very nicely covered on a balanced diet. Just I would like to cover here that in order to have a meaningful weight loss of 5%, you just need to cut down on around 500 to 700 calories per day from the diet. This is not a big task, this is an easy task, relatively easier task, and it can be done in clinical practice. Losing maybe 10 or 15% may be difficult for the patient, but 5% weight loss is of course possible in majority. Physical activity has already been emphasized by sir, at least 150 minutes of moderate intensity exercise or 75 minutes of rigorous exercise, and this should include resistance training also, at least 2 to 3 sessions of resistance training. You should have behavioral modifications in people with diabetes, having obesity. So behavioral modification can be small things. It can be like just advising the patient to take the stairs at work. It can be advising them not to use vehicles or scooters when you're going to going to purchase your groceries. So any small intervention, behavioral modification can lead on to significant weight loss. So this is the treatment options in people with overweight or obesity. If you see in the bracket, this is where we fall. The overweight is 23 to 24.9 and the obese is more than 25. So in all categories you need diet, exercise and behavioral modification. In people who are having a BMI more than 25, you can institute pharmacotherapy. So this is with respect to our population, and metabolic surgery has also been advised in people who are having difficult to control diabetes, especially who are having a BMI more than 27.5. But whether it is done or not is a different question altogether. These are the currently approved medications for weight loss. You have the Orlistat, which is available in our market, which gives a very modest weight loss of 3 to 5%. And the other drugs which I mentioned here, the naltrexone, bupropion, the phentermine topiramate, liraglutide at 3 mg dose, all these are not available in our market. You have promising new agents like semaglutide 2.4 mg. In the STEP trials, it has shown to give significant weight loss to the tune of 15 to 18% in the various STEP trials. Then you have tirzepatide, which is a dual agonist, dual GIP, GLP and GIP agonist, which gives significant weight loss. So the SURPASS trials were in people with diabetes, which showed a weight loss of between 12 to 15%. You have the SURMOUNT trial, which at the highest dose of tirzepatide gave weight loss of around 21%. And all these are very promising. You have many newer molecules which are coming into the, which are in various phases of clinical trials, which I won't be discussing here. You have non-surgical interventions for very obese people. Some of these are the intragastric balloons for people who are having a BMI more than 25. It gives a modest weight loss of 7 to 15%. The endoscopic sleeve gastroplasty, which is again a reversible procedure and can give a weight loss of 15 to 20%. You have metabolic surgery, which has proven benefits with respect to remission of diabetes and remission of various other metabolic conditions. But the problem is that the public acceptance to the surgery is very minimal. The US data shows that only 0.4% of eligible people for obesity surgery or metabolic surgery actually undertake the procedure. You have a lot of complications after these bariatric procedure, and they need proper follow-up. So just a question to the listeners. So once if a patient has achieved post-diabetes or remission and someone who is having pre-diabetes, do you feel both of them having an A1C of 6.2, do you feel that both of them have the same cardiovascular disease risk? Anyone wants to take this question? So I'll just conclude. So my main crux was on weight loss. So a patient who has entered remission, that is defined as an A1C less than 6.5, and a patient who is having pre-diabetes, both of them have different cardiovascular risk. In that the pre-diabetic person has a more increased cardiovascular disease risk. They have a more atherogenic lipid profile. They have hypertension as a risk factor and various other risk factors which increase their cardiovascular disease risk. But in patient who has entered remission, they actually, in addition to like being free of diabetes, they have improvement in their lipids, improvement in their blood pressures, and therefore they have improvement in their cardiovascular risk. So just I'll be skipping these. So in conclusion, type 2 diabetes, one of the problems that we have in type 2 diabetes is the increased ectopic fat deposition which the body can cope up with. This ectopic fat is not inert. This this leads on to a cycle which, the twin cycle, where there is deposition of fat inside the liver, inside the pancreas, stunning the pancreas, causing dedifferentiation and increase in the blood sugars. Any degree of weight loss in people with diabetes is beneficial, but minimum 5% weight loss can give you clinically meaningful results. So in our busy clinical practice, we have to find some time to motivate people, especially with overweight and obesity, to lose weight. And this step is very easy with simple lifestyle modifications. So we have to follow an upstream method where you are targeting all the risk factors, including obesity, in order to better manage people with diabetes. So lifestyle modification still holds key, and you have all the newer promising agents like the semaglutide 2.4 and the tirzepatide, which will give you clinically meaningful weight loss and improve the cardiometabolic risk also in our patients. So thank you all for the patient listening. So lose weight for good, and thank you.
Thank you, Dr. Tony, for the comprehensive presentation. Now the topic is open for discussion. Any questions, queries?
So lifestyle modification is the first key to weight loss. But what about drugs like oral semaglutide? Is it currently available? Is it costly?
Sir, semaglutide is currently not available in our market, but probably by next year, semaglutide 2.4 weekly injection might be available. That is what I came to know from the Novo representatives.
Oral preparations?
No, oral preparation already we have, but that is not the one approved for weight loss. The one approved for weight loss is the injectable semaglutide weekly at a dose of 2.4. So you don't start with 2.4, you start with a lower dose and then gradually build it up.
It's going to be quite expensive.
It will be expensive, sir. But as the use increases, the number of people using these drugs increases, I think the cost might come down, because obesity also has a very high prevalence, more than that of diabetes.
Dr. Tony, what do you think is the better indicator of BMI or is the waist ratio?
So definitely waist circumference is a better indicator of BMI because that indirectly represents your the visceral fat deposition, the subcutaneous fat deposition. The BMI may not always represent your actual fat because in very muscular individuals or athletic individuals, they might be having a higher BMI, but the fat mass might be lower. So you have to have a ethnic waist circumference cutoff.
So in that context, what about the feasibility of liposuction reducing the...
So liposuction only takes away the subcutaneous fat. It doesn't address the visceral fat. The visceral fat is the one causing all the problems.
But of course, when you do liposuction, the waist circumference decreases. Waist circumference decreases.
Waist circumference decreases, sir, but usually it regains over time.
Oh, it
And if you see the metabolic impact that it has, it is minimal or nil. There is no improvement in the blood sugars or lipids as per various constants.
Now, how much exercise do you recommend for reducing body weight?
Sir, first thing we have to emphasize is that exercise is beneficial for the cardiovascular health. Okay? And there are many people who follow exercise alone for weight loss, and they are not able to lose weight. They tell you that I have exercised for 1 or 2 hours per day, but still I am not losing weight. The problem there is that after exercise, these people tend to eat more, and this compensates for all the calorie loss that they have. We know that walking for 1 hour, maybe you might lose around 200 or 250 calories, but eating maybe a small amount of food will give you back that calorie. And if you are overeating after exercise, you will regain, or you will not lose that calories that you have actually lost during the exercise. So exercise alone for weight loss is not recommended. You should combine it with lifestyle modification and dietary modification. You should follow a low-calorie diet along with exercise in order to lose weight. If you see the exact percentage of weight loss that is contributed by calorie restriction and weight loss, I would say it is 80% for the dietary restriction and 20% from the weight loss. Weight loss is actually modest for with exercise alone.
There are one more question. Is keto diet beneficial?
So, sir, we don't have RCTs to actually back that, but short-term, people without diabetes, short-term keto diet, I don't think will harm them. But of course, the risk of renal stones, the risk of renal stones actually increases after, and gallstones also increase. So we don't have long-term studies to back whether keto diet is beneficial in the long run.
Thank you, Dr.
Sir, I have a question. Very excellent scientific presentation, sir. What is the role of intermittent fasting in diabetic patients and those people who are having family history of diabetes?
So intermittent fasting is beneficial for any person, be it people with diabetes or any metabolic risk factor of obesity. Intermittent fasting basically means that you are giving the body time to go into a fasting state. When you are allowing your body to fast, you are actually activating the compensatory mechanisms that we had earlier on to survive, and this leads on to repair, regeneration of various body cells. So actually, if you are looking at intermittent fasting as a form of weight loss, it will be very modest. But if you are looking at intermittent fasting as a form of for improving your cardiovascular, for reducing your risk of cardiovascular disease or improving your diabetes, that will be more beneficial.
Thank you, sir.
Drug for diabetes, or will it recur after stopping the injection?
I didn't get your question, sir.
Suppose we start semaglutide for weight reduction and diabetes reversal for a patient, and once we stop the injection, will it recur or not?
Sir, it depends on the weight we gain. I don't think it will solely depend on whether you are stopping the drug. If you are losing a significant amount of weight and you are able to achieve an A1C
have shown this fentermine dopamine combination has shown to reduce weight by 7%. So is it available in our?
Actually, fentermine dopamine is not available in our market. It is available only in US. Okay, but we do have topiramate. Fentermine dopamine combined will give you a weight loss of between 8 to 10%. Okay. We do have topiramate. Topiramate we do give over the counter in patients who are having conditions like epilepsy or migraine disorders where they have obesity associated with it. So we can, of course, we can try these medications over the counter. Just be careful of their side effects like renal stones, ankylosing glaucomas, etc. And slowly titrate it. And if there is no response, that is a clinically meaningful weight loss of at least 5% or no weight loss at all in the next 3 months, better to stop with it.
And if there are no more questions, thank you, Tony, for your presentation on behalf of the Department of Medicine as well as Assembly of the Department.
Thank you so much, sir, for your content-rich presentation. I now request the chairpersons, Dr. Rajashekharan C. and Dr. Jayesh, to present the memento and certificate to Dr. Tony P. Joseph. Thank you, sir. I now invite our respected faculty, Dr. Lakshmi Sarayu, Head of the Department of Microbiology, to hand over the memento and certificate to the chairpersons. Thank you, ma'am.
Towards the inauguration program. First and foremost, I would like to invite our Honorable Chairman, Sri M. Abdul Aziz sir, to this auspicious occasion. May I also invite our respected director, Dr. Anas Aziz, onto the dais. It's my privilege to invite our respected principal, Dr. K. Sashikala ma'am, onto the dais. I also invite Dr. Srikantan K., Head of Department of General Medicine, Azizia Medical College, and Dr. Rajashekharan C., Professor, Department of General Medicine, Azizia Medical College, to the CME program. Let's begin the section by invoking the blessings of Almighty. I request you all to kindly rise for 1 minute silent prayer. Thank you. Please be seated.
Once again, I would like to cordially invite all the people on and off the dais to our CME program, Adamcon 2022, Annual Conference Pioneering Towards Diabetic Advances. With immense pleasure, I invite Dr. Rajashekharan C., Professor, Department of General Medicine, Azizia Medical College, to deliver the welcome speech.
Good morning. So standing in an alluring and sprawling campus of Azizia Medical College, I would like to begin with a simple quote. The proper use of science is not to conquer nature, but to live with it. This is by Barry Commoner, the American biologist. Ladies and gentlemen, dignitaries on and off the dais, it gives me a great happiness and privilege to commence this auspicious occasion by heartily welcoming you all to the annual conference of NCME devoted to advance of medicine. As you all know, the world is fast changing, and this can be witnessed in the wake of life when mankind is facing a heat of modern life as the incidence of chronic lifestyle diseases are on the rise. Among this, diabetes is considered to be a health issue of global concern due to its wider prevalence and far-reaching consequences. I would say it's a dwindling pandemic. Kerala is the diabetes capital of India, and it is in this context that we are organizing the CME with diabetes as a main theme, the Adamcon 2022. With immense pleasure, I welcome our beloved chairman of ASIA Institution, Sri Abdul Aziz Sir, the patron, the backbone of ASIA Group and the Podikunnu Musliar Charitable Education Trust, who has an enormous contribution towards the growth and welfare of the society through imparting higher education. His contributions are many to many corporate and social responsibilities, thereby creating competent and liberal-minded individuals and bringing good practices in the healthcare closer to the home. This is expected to blaze a trail of corporate social commitment in the field of rural health care in the years to come. He owns the golden thread through the ethos of ASIA of social commitment. We welcome you, dear sir, respected sir, chairman, Sri Abdul Aziz sir, for being a patron of Adamcon CME. Now, to serve as the backbone of the organization, we have a director board comprising of Dr. Ansar Aziz, Dr. Hashim Aziz, Dr. Miraj Aziz, and Dr. Anas Aziz, and Dr. Hassan Aziz, who have been imparting such a great responsibility in the various fields of the organization and to assure its flawless, strict, and stringent social empowerment. It's my great delight to welcome Dr. Anas Aziz, consultant pediatrician at St. Mary College, KOLLAM, onto the dais. Now, our principal, Professor Shashikala Madam, is giving us support, guidance, and expert opinion, is always with us. With all pleasure and privilege, let me welcome Madam to our CME Adamcon 2022. Now, we'd like to welcome all the chairpersons, the speakers, our annual conference to our annual conference Adamcon, whose presence and privilege always add fascinating colors to our conference. I cannot move ahead without saying a few words about our department headed by Professor Srikanthan, which sometimes is delightfully chaotic with fruitful mess of with a feeling of love and splendid adventure. Yes, it's our Department of General Medicine. We have our mentor, Dr. Srikanthan, HOD and professor, who has been here from the very birth of the ASIA and has served his best for the department for the empowerment of the institution. Heartily, I welcome you, sir, to Adamcon 2022. Now we have Professor Anil Vijaykumar, Dr. Sashidharan, Senior Consultant, Dr. Amitan, Associate Professor, the resident physicians, including Dr. Hari Krishnan, Dr. Jaya, Dr. Rais Iqbal, Dr. Jay Surya, Dr. Jafin Bashir, Dr. Mohammad Iqbal, and our beloved postgraduate and secretaries. Also, we have other department facilities, faculties furnishing to a glow of our institution. The delegates and other participants are heartily welcome to the conference. Once again, on behalf of all, from top to bottom of Assisia, I welcome you all to the Adamcon 2022, the annual conference and CME on pioneering towards diabetic advances. Let's gather together and make an occasion at its best diabetic care. Let me conclude my words. Thank you. Thank you.
Thank you so much, sir. I am extremely delighted to invite Shri M. Abdul Aziz, sir, our Honorable Chairman, Azizia Group of Institutions, to inaugurate the CME program and deliver the presidential address.
Good morning. Dr. Abhilash Nair, Dr. Tony P. Joseph, Dr. Baby K. Matthew, Dr. Amitan, Joseph Vinu, Anil Robi, Principal Dr. Shashigala, Dr. Srigandan, Dr. Rajeshekaran, Dr. Shashidharan, Dr. Anil Vijayumar, Dr. Amit, വേദിയിലും സദസ്സിലും ഇരിക്കുന്ന വിശിഷ്ട വ്യക്തികളെ, മഹത്തായ ഈ ഒരു പരിപാടിയിൽ നിങ്ങളോടൊപ്പം പങ്കുചേരാൻ സാധിച്ചതിൽ വളരെയേറെ സന്തോഷിക്കുകയാണ്. വളരെ ദൂരത്തു നിന്നും ഒരുപാട് ജോലികൾ ഉള്ള ആൾക്കാരാണ് ഇവിടെ വന്നിരിക്കുന്ന പ്രഗത്ഭരായ ഡോക്ടർമാർ. ഇതുകൊണ്ട് നമ്മൾ ഈ പ്രോഗ്രാം കൊണ്ട് ഉദ്ദേശിക്കുന്നത് പ്രമേഹ ചികിത്സാ രംഗത്തെ മാറ്റങ്ങളെക്കുറിച്ച് ഒരു സമഗ്ര പഠനം നടത്തുന്നതിന് വേണ്ടി നമ്മുടെ സമൂഹത്തിലെ പുതു ഡോക്ടർമാർക്ക് അവബോധം നൽകുകയും ലോകാരോഗ്യ സംഘടനയുടെ ഈ വർഷത്തെ അവരുടെ പ്രമേയത്തിൽ പറഞ്ഞിട്ടുള്ളത് എല്ലാവർക്കും, എല്ലാ ഡയബറ്റിക് രോഗികൾക്കും ചികിത്സ നൽകുക എന്നുള്ളതാണ്. ആ പ്രഖ്യാപനം നമ്മൾ ഉൾക്കൊണ്ടുകൊണ്ട് ഇവിടെ കൂടിയിരിക്കുന്ന നമ്മളെല്ലാവരും അത് പ്രാവർത്തികമാക്കണം എന്നുള്ളതാണ് എനിക്ക് ഈ അവസരത്തിൽ നിങ്ങളോട് അഭ്യർത്ഥിക്കാനുള്ളത്. വേൾഡ് ഡയബറ്റിക് ഫെഡറേഷൻ്റെ കണക്കനുസരിച്ച് ഈ ബ്രോഷറിൽ ഞാൻ കാണുന്ന 2011 362 മില്യൺ പീപ്പിളിനാണ് ഡയബറ്റിക് രോഗികളായിട്ടുള്ളത്. അത് 2030 ആകുമ്പോഴത്തേക്ക് 562 മില്യൺ രോഗികളാണ് വരാൻ പോകുന്നതെന്നുള്ളതാണ് ഞാൻ ഈ ബ്രോഷർ നോക്കിയപ്പോൾ അതിൽ നിന്ന് മനസ്സിലാവുന്നത്. അപ്പോൾ നിങ്ങളുടെ എല്ലാം ശ്രമഫലമായി, നിങ്ങളുടെ എല്ലാം അശ്രാന്ത പരിശ്രമം കൊണ്ടാണ് പുതിയ പുതിയ ചികിത്സകൾ കണ്ടുപിടിക്കാനും പുതിയ മരുന്നുകൾ കൊടുക്കാനുമുള്ള ഒരു പുതിയ തീരുമാനങ്ങൾ എടുത്തിരിക്കുന്നത്. ഞാൻ കഴിഞ്ഞ ദിവസം നമ്മുടെ രാജശേഖരൻ ഡോക്ടറായിട്ട് എന്നെ ക്ഷണിക്കാൻ വന്നപ്പോൾ അദ്ദേഹം പറഞ്ഞത്, ഡയബറ്റിക് രോഗത്തെ സംബന്ധിച്ച് ഇപ്പോഴൊരു തിരിച്ചുവരവ് വന്നിരിക്കുകയാണ്. ഞാൻ എൻ്റെ എല്ലാ കാര്യങ്ങളും നഷ്ടപ്പെട്ടു പോയി, ഞാനിതിൽ നിന്ന് വിമുക്തനാകത്തില്ല എന്ന് കരുതിയിരുന്ന പല രോഗികളും വളരെ വ്യത്യസ്തമായി അവരുടെ ആ പഴയ ജീവിതത്തിലേക്ക് വരാൻ തുടങ്ങി എന്നുള്ളതാണ് ഡോക്ടറിൻ്റെ അടുത്ത് പറഞ്ഞത്, അല്ലേ? അതെനിക്ക് വളരെ സന്തോഷമായി. പണ്ടൊക്കെ എന്ന് പറഞ്ഞാൽ നമുക്ക് ഈ ഡയബറ്റിക് രോഗികളെ സംബന്ധിച്ച് നമ്മളൊക്കെ വീട്ടിൽ, എൻ്റെയൊക്കെ കുഞ്ഞിനെയുള്ള എൻ്റെ കുടുംബത്തിൽ ഒരുപാട് ആൾക്കാർ ഷുഗറിൻ്റെ അസുഖം എന്ന് പറയും. ഷുഗറിൻ്റെ അസുഖം വന്നു കഴിഞ്ഞാൽ അതോടുകൂടി അവൻ്റെ ജീവിതം പോയി എന്നാണ് കണക്കൂട്ടിയിരുന്നത്. നമ്മളൊക്കെ കുടുംബത്തിൽ നിന്ന് എൻ്റെ കുഞ്ഞിലേക്ക് ഒരുപാട് ആളുകൾ മരണപ്പെട്ടിട്ടുണ്ട്. ഡയബറ്റിക് രോഗം വന്ന് ഷുഗറിൻ്റെ അസുഖം, പഞ്ചസാരയുടെ അസുഖം എന്ന് പറയും. ഈ പഞ്ചസാരയുടെ അസുഖം വന്നു കഴിഞ്ഞാൽ അവർ ട്രീറ്റ്മെൻ്റ് ഇല്ല, എന്തെങ്കിലും കഷായങ്ങളൊക്കെ കുടിച്ച് കുറേ നാളിങ്ങനെ ജീവിക്കും. അതോടുകൂടി കണ്ണിൻ്റെ കാഴ്ച പോവും, കിഡ്നി പോവും, അങ്ങനെ മരണപ്പെട്ടുകൊണ്ടിരിക്കുന്ന ഒരു കാലഘട്ടമായിരുന്നു ഇതിനു മുമ്പ്. നിങ്ങളെപ്പോലുള്ള പ്രഗത്ഭരായ ഡോക്ടർമാരുടെ റിസർച്ച് കൊണ്ടും ശ്രമഫലമായി നമുക്ക് ഒരുപാട് അഡ്വാൻസ് ട്രീറ്റ്മെൻറ്റുകൾ നമുക്ക് പഠിക്കാൻ സാധിച്ചിട്ടുണ്ട്. അത് ജനങ്ങൾക്ക് എത്തിച്ചു കൊടുക്കുക എന്നുള്ളതാണ് നമുക്ക് ഈ അവസരത്തിൽ നമ്മൾ ചെയ്യേണ്ടത്. അതേപോലെ ഈ പുതുതലമുറയിലെ യുവ ഡോക്ടർമാരുണ്ട്. അവർക്ക് നമ്മൾ നിങ്ങളുടെ മെസ്സേജുകൾ ഇപ്പോൾ ഈ ഡോക്ടർ സംസാരിച്ച പോലെ എന്തെല്ലാം അഡ്വാൻസ് ട്രീറ്റ്മെൻ്റ് ഉണ്ട് അതെല്ലാം അവർക്ക് പറഞ്ഞു കൊടുത്ത് മുന്നോട്ട് പോയാൽ നമുക്ക് ഒരുപാട് രോഗികളെ നമുക്ക് രക്ഷിച്ചെടുക്കാൻ കഴിയും എന്നുള്ളതാണ് എനിക്ക് ഈ അവസരത്തിൽ പറയാനുള്ളത്. ഞാനൊരു ദീർഘമായ പ്രസംഗത്തിന് വേണ്ടി ഡോക്ടർ എനിക്കൊരു വലിയ പ്രസംഗം എഴുതി തന്നു. പക്ഷേ ഞാനത് കണ്ടില്ല. ഞാൻ ഇന്ന് രാവിലെ വന്നപ്പോഴാണ് ഈ ഷാജി എൻ്റെ കയ്യിൽ തരുന്നത്. ഞാനത് പറഞ്ഞു അതിനുള്ള സമയം പഠിക്കാനില്ല എന്ന് പറഞ്ഞ് ഞാൻ അതങ്ങ് തിരിച്ച് ഷാജിയുടെ കൊടുത്ത്. അതുകൊണ്ട് ഞാൻ ദീർഘിപ്പിക്കുന്നില്ല. ഇവിടെ നിന്ന് നിങ്ങൾ ഇവിടെ വന്നിട്ടുള്ള എല്ലാവർക്കും എല്ലാവിധ ആശംസകളും നേർന്നുകൊണ്ട് നമ്മുടെ ഈ പരിപാടി സംഘടിപ്പിച്ച നമ്മുടെ ഇവിടുത്തെ SR ഡോക്ടർ ജയസൂര്യ, ഡോക്ടർ ജയ, ഡോക്ടർ ഇർഫാൻ, ഡോക്ടർ റൈസ്, ഡോക്ടർ മുഹമ്മദ് ഇക്ബാൽ, ഹരികൃഷ്ണൻ, അതിനോടൊപ്പം തന്നെ നമ്മുടെ രാജശേഖരൻ ഡോക്ടർ, നിങ്ങളെല്ലാവരും വളരെ അശ്രാന്ത ഫലം ഇതിനു വേണ്ടി നിങ്ങളുടെ എല്ലാ സമയങ്ങളും ഒരുപാട് ദിവസത്തെ സമയങ്ങൾ ഇതിനു വേണ്ടി നിങ്ങൾ ബുദ്ധിമുട്ടിയാണ് ഈ പരിപാടി ഇങ്ങനെ ഈ ഒരു ലെവലിൽ കൊണ്ടുവന്നത്. ഇതേപോലെ നിങ്ങൾ ഈ ചെയ്ത ഈ ഡിപ്പാർട്ട്മെൻറ്റ് CME പോലെ ഈ മെഡിസിൻ ഡിപ്പാർട്ട്മെൻറ്റാണ് എനിക്ക് ഏറ്റവും കൂടുതൽ എൻ്റെ ഹോസ്പിറ്റലിൽ ഏറ്റവും കൂടുതൽ എനിക്ക് താല്പര്യമുള്ളൊരു ഡിപ്പാർട്ട്മെൻറ്റ് മെഡിസിൻ ഡിപ്പാർട്ട്മെൻറ്റാണ്. എന്തുകൊണ്ടാണ്? നിങ്ങൾ അശ്രാന്ത പരിശ്രമം ചെയ്താണ് ഹോസ്പിറ്റലിൽ പേഷ്യൻറ്റിനെ കിടത്തുന്നതിന് വേണ്ടിയും പേഷ്യൻറ്റ് ട്രീറ്റ്മെൻറ്റ് കൊടുക്കുന്നതിന് വേണ്ടിയും വളരെ ബുദ്ധിമുട്ടുന്ന ഒരു ഡിപ്പാർട്ട്മെൻറ്റ്. ബാക്കിയുള്ളവരൊന്നും ബുദ്ധിമുട്ടുന്നതെന്ന് പറയല്ല. പക്ഷേ നിങ്ങളുടെ ഈ പ്രവർത്തനങ്ങൾ മാതൃകയാക്കിക്കൊണ്ട് ബാക്കിയുള്ള എല്ലാ ഡിപ്പാർട്ട്മെൻറ്റുകാരും ഇത് മുന്നോട്ട് ഇതേപോലെ CMEകൾ നടത്തി ജനങ്ങൾക്ക് ആവശ്യമുള്ള കാര്യങ്ങളിലോട്ട് ഇറങ്ങിയാൽ എൻ്റെ ഭാഗവും ഞാനും എൻ്റെ ഒരു കോൺട്രിബ്യൂഷനും ഇതിനു വേണ്ടി ഉണ്ടായിരിക്കും എന്ന് പറഞ്ഞുകൊണ്ട് ഈ പരിപാടിയിൽ പങ്കെടുത്ത എല്ലാവർക്കും എല്ലാവിധ ആശംസകളും നേർന്നുകൊണ്ട് പ്രത്യേകിച്ച് എൻ്റെ അയലത്തുകാരനായ ഡോക്ടർ അനിൽ വിജയകുമാർ, ബാക്കി എനിക്ക് പേരെടുത്ത് പറയാൻ ആരെയും മനസ്സിലാവുന്നില്ല, എല്ലാവർക്കും എല്ലാവിധ ആശംസകളും നേർന്നുകൊണ്ട് നിർത്തുന്നു. നന്ദി, നമസ്കാരം.
Thank you, sir, for your kind words. Now, I heartily call upon our respected director, Dr. Anas Aziz, sir, for the felicitation.
Respected Chairman, our beloved Principal, the dignitaries on the dais, our Department of Medicine faculty members, other eminent delegates, residents and staff. First of all, I would like to appreciate and congratulate the Medicine Department for organizing this wonderful CME, especially our HOD and Dr. Rajshekharan sir. Then I am very glad to be here in the presence of eminent delegates, endocrinologists and senior physicians from various hospitals. I once again, on behalf of the management, I welcome you all to this gathering. As we all know that Kerala is the capital of diabetes in India. And India being the second rank in the world among the other countries. So even though our health indices are high in Kerala, we are still researching on how this diabetic incidence is more in Kerala and in India. Even the juvenile diabetes, pediatric diabetes, that prevalence is also increasing, especially in Kerala and Tamil Nadu. So I hope these seminars, these CME, like pioneering towards diabetes advances. So this CME will definitely enhance our treatment and helps us in the management of diabetes. And we should focus more on the screening and early detection of the cases so that we can prevent further complications of the diabetes. So I wish all the best for this CME, and with these few words I am concluding. Thank you.
Thank you, sir. Next, I warmly welcome our respected principal, Dr. Shashigala ma'am, to address the gathering.
ബഹുമാനപ്പെട്ട ചെയർമാൻ, അസീസിയ ഗ്രൂപ്പ് ഓഫ് ഇൻസ്റ്റിറ്റ്യൂഷൻസ്, ബഹുമാനപ്പെട്ട മാനേജിംഗ് ഡയറക്ടർ, എൻ്റെ രണ്ട് ഗുരുനാഥന്മാർ ശ്രീകാന്തൻ സാറും രാജശേഖരൻ സാറും, മെഡിസിൻ ഡിപ്പാർട്ട്മെൻറ്റിലെ ഓരോ അംഗങ്ങൾ, ഈ CMEക്ക് പല സ്ഥലത്തു നിന്നും ഇവിടെ വന്ന ഡെലിഗേറ്റ്സ്, അസീസിയ മെഡിക്കൽ കോളേജിലെ വിദ്യാർത്ഥിനികൾ, മറ്റ് അധ്യാപകർ, അധ്യാപകേതര ജീവനക്കാർ. എനിക്കിന്ന് വളരെ സന്തോഷമുള്ളൊരു ദിവസമാണ്. കാരണം രാജശേഖരൻ സാറ് ഒരു മാസം മുമ്പ് ജയസൂര്യമൊത്തൊരു ദിവസം എൻ്റെ മുറിയിൽ വന്നിട്ട് ഒരു CME നടത്താൻ പോവുകയാണ് വേൾഡ് ഡയബറ്റിക് ഡേയുടെ ഭാഗമായിട്ട് എന്ന് പറഞ്ഞപ്പോൾ ഇത് ഇത്രയും വലിയൊരു സംഭവം ആവുമെന്നന്ന് ഞാൻ വിചാരിച്ചില്ല. മിനിഞ്ഞാന്ന് ഞാൻ ഇങ്ങനെ ഇരിക്കുമ്പോൾ എന്നോട് പറയുന്നു പ്രസ് ക്ലബ്ബിൽ മീറ്റിങ്ങിന് പോകുന്നു. അപ്പോഴാണ് ഞാൻ മനസ്സിലാക്കിയത് ഒരു വലിയൊരു സംരംഭമായിട്ടാണ് അവരതിനെ ഓർഗനൈസ് ചെയ്തതെന്ന്. ഇപ്പം ഞാൻ രാവിലെ വന്നപ്പോൾ ഞാൻ കുറച്ചുകൂടെ മുന്നേ വന്നില്ലല്ലോ എന്ന് എനിക്കൊരു സങ്കടം ഉണ്ടായിരുന്നു. ഞാൻ ഡയബറ്റിക്കാണ്. ഒബീസിറ്റിയും ഡയബറ്റീസും എങ്ങനെ ആണ് റിലേറ്റഡ് ആയിട്ടിരിക്കുന്നതെന്ന് ഇപ്പോൾ ലേറ്റസ്റ്റ് കാര്യങ്ങൾ എനിക്ക് മനസ്സിലാക്കാൻ പറ്റിയത് ഡോക്ടർ ടോണിയുടെ പ്രസൻറ്റേഷനിൽ നിന്നാണ്. എനിക്ക് തോന്നുന്നു കുറച്ച് പേരെങ്കിലും എൻ്റെ സ്റ്റുഡൻസും ആയിരിക്കും. ഡോക്ടർ ടോണി ട്രിവാൻഡ്രത്ത് പഠിച്ചതാണെങ്കിൽ 2008, 11, 14, 15 കാലഘട്ടം ഒഴികെ ബാക്കി 32ഓളം കൊല്ലം ഞാൻ തിരുവനന്തപുരത്ത് തന്നെ ഉണ്ടായിരുന്ന ഒരാളാണ്. മിക്കവാറും പഠിപ്പിച്ചിട്ടുണ്ടാവും. എന്തായാലും വളരെ അഭിമാനപൂർവമായ ഒരു നിമിഷമാണ്. കാരണം അസീസിയ മെഡിക്കൽ കോളേജ് ഒരു അധ്യാപനത്തിലായാലും രോഗി പരിചരണത്തിലായാലും വളരെ വളരെ മുന്നേറിക്കൊണ്ടിരിക്കുന്ന ഒരു കാലഘട്ടമാണിത്. ഇത്തരം സംരംഭങ്ങൾ ആക്ച്വലി രാജശേഖരൻ സാർ ഒരാഴ്ച മുൻപ് വേറൊരു പ്രോജക്റ്റിനെ പറ്റി സംസാരിക്കുകയുണ്ടായി. അതും കൂടെ വരികയാണെങ്കിൽ സമൂഹ മധ്യത്തിൽ നമുക്ക് നൽകാൻ കഴിയുന്ന ആരോഗ്യ പരിപാലനങ്ങൾ വളരെ വലുതായിരിക്കുമെന്നും അത് ഒരു ആരോഗ്യ പരിപാലന രംഗത്ത് വളരെ വലിയ മാറ്റങ്ങൾ തന്നെ ഉണ്ടാക്കുമെന്ന് ഞാൻ വിചാരിക്കുന്നു. അതുപോലെ നമ്മുടെ കമ്മ്യൂണിറ്റി മെഡിസിൻ ഡിപ്പാർട്ട്മെൻറ്റിൻ്റെ ഒരു സ്പർശ് എന്ന് പറഞ്ഞൊരു പ്രോഗ്രാമുണ്ട്. ഇപ്പോൾ NMCയുടെ ഡയറക്ഷൻ വഴി വന്നതാണെങ്കിൽ പോലും മാസം തോറും നമ്മളൊരു കമ്മ്യൂണിറ്റി ക്ലിനിക്ക് ഇപ്പോൾ നടത്തുന്നുണ്ട്. അതിന് വലിയ ഒരു സപ്പോർട്ടാണ് സമൂഹത്തിൽ നിന്നും കിട്ടിക്കൊണ്ടിരിക്കുന്നത്. അതിനേക്കാളുപരി എനിക്ക് വേറൊരു സന്തോഷം കൂടെ ഉണ്ട്. 15-ാം തീയതി ഞങ്ങളുടെ 2022 MBBS അഡ്മിഷന് ക്ലാസ് തുടങ്ങുകയാണ്. അപ്പോൾ അവർക്കൊരു സർവേ കൊടുക്കണമായിരുന്നു, ഒരു പ്രോജക്റ്റ്, ചെറിയൊരു പ്രോജക്റ്റ് ആ സ്റ്റുഡൻസിന്. അതിനെന്ത് ടോപ്പിക്ക് കൊടുക്കുമെന്നിങ്ങനെ വിഷമിച്ചിരുന്നപ്പോഴാണ് ഇപ്പോൾ ഡോക്ടർ ടോണിയുടെ ഡയബറ്റീസിനെ പറ്റിയുള്ള പ്രസൻറ്റേഷൻ കേട്ട് കഴിഞ്ഞപ്പോൾ ടോപ്പിക്കിന് പഞ്ഞൊന്നുമില്ല എന്നെനിക്ക് മനസ്സിലായി. നാളെ കമ്മ്യൂണിറ്റി മെഡിസിൻ ഡിപ്പാർട്ട്മെൻറ്റുമായിട്ട് ചേർന്ന് ഞങ്ങൾ ആ ഒരു ടോപ്പിക്കിൽ നമുക്ക് സമൂഹത്തിൽ ഒരു സർവേ നടത്താൻ പറ്റിയ പോയിൻറ്റ്സ് എടുത്ത് സർവേ നടത്താമെന്ന് വിചാരിക്കുന്നു. എന്തു തന്നെ ആയാലും ജനറൽ മെഡിസിൻ ഡിപ്പാർട്ട്മെൻറ്റ് ഇത്തരം ഒരു CME ഓർഗനൈസ് ചെയ്തത് വളരെ വലിയൊരു കാര്യമാണ്. കാരണം എല്ലായ്പ്പോഴും ഗുഡ് ക്ലിനിക്കൽ പ്രാക്ടീസ് ആണ് ദ ബേസിസ് ഓഫ് ക്ലിനിക്കൽ പ്രാക്ടീസ്. ആ ഗുഡ് ക്ലിനിക്കൽ പ്രാക്ടീസ് നമുക്ക് സ്വായത്തമാവണമെങ്കിൽ പീരിയോഡിക്കായിട്ട് നമ്മൾ ഓരോ കാര്യങ്ങളിലും അപ്ഡേറ്റഡ് ആവണം. ഇത്തരം CMEs അതിൻ്റെ എല്ലാം ഒരു ഫൗണ്ടേഷനാണ് എന്നുള്ളതിൽ യാതൊരു സംശയവും ഇല്ല. വൺസ് അഗെയിൻ I thank one and all in the Department of General Medicine who are behind the organizing of this grand CME on the World Diabetic Day. Thank you all, and I wish all the best to this CME.
Thank you, ma'am. With great pleasure, let me now call upon Dr. Srikantan K., Head of the Department of General Medicine, Azizia Medical College, for the felicitation.
Good morning to all. Respected Chairman Mr. Abdul Aziz, Director Dr. Anas Aziz, Principal Dr. Sigala Madam, Dr. Rajsekharan, other faculty members of Department of Medicine, Head of the Department, other staff members of other departments, postgraduate students, and other hospital staff and medical students. We all know that Diabetes Day falls on November 14th. That is the birthday of Banding, the co-inventor of insulin. Even though the date is on tomorrow, we conducted the day, and it is a celebration 13th because it's a holiday, Sunday. We know that about 1 in 10 people are diabetic, as a world level, but it may be more in Kerala. And only 40% are diagnosed as having diabetes. The rest is not diagnosed. And now, even though the age group is more than, earlier it was more than 40 years only. Now it is even with 30, we are getting diabetes. And about 50 lakh people are there in teen age group. That is age below 20 are also diabetic. The theme, every year there is a theme for Diabetes Day is there. It is the access to the care of diabetes. That is the theme 2021 for two years, up to 2023. That is the theme is access to diabetic care. This year, access to diabetes education. Education means education of the health professionals who are educating the public and the patients. Then educate, and then the people also, education the people, patients. So access to diabetic education is most important. This CM is conducted as a part of access to education for health professionals. So if the professionals can educate the people and the patients, then only the treatment will become more effective. So I facilitate this day. Thank you all.
Thank you, sir.
Erectile dysfunction is the most common male sexual dysfunction and shares many risk factors with systemic conditions including cardiovascular diseases and metabolic syndromes. It is important to remember that erectile dysfunction is considered to be an independent risk factor for cardiovascular diseases and can be a harbinger of future cardiovascular events. Now, let's move on to the fifth section, which is chaired by Dr. Rajendran S., Consultant Neurologist, Azizia Medical College, and Dr. Ajish TP, Consultant Endocrinologist, Travancore Medicity. Please occupy the chair, sir. I invite Dr. Bobby K. Matthew, Consultant Endocrinologist, WellCare Hospital, Cochin, for speaking a few words on the topic metabolic syndrome and erectile dysfunction.
Good morning. Hello. Good morning. Welcome to the new session, erectile dysfunction with dysfunction in diabetes is a common presenting problem to the clinicians. Hello? It may present to the urologist, endocrinologist, or general medicine people. But we are seeing only the tip of the iceberg. Many patients are reluctant to tell their problems. They have to elicit from the history. They will tell indirectly different problems. Finally, we can elicit only for leading questions really able to elicit. Because during the last 40 years, lot of advances are made in the neurological tissue level, biochemical level. Now we are able to understand fully the physiology of erection. So I think the speaker will going to elaborate on these details. So welcome Dr. Bobby.
Yes, yes.
Presentations.
Something about erectile dysfunction, but more in relation about erectile dysfunction and diabetes or metabolic syndrome. When we all used to study for MBBS MD, there was an MCQ question, what's the biggest risk factor for ED? So Davidson, Harrison, everything used to say it is diabetes mellitus. So it can be type 1, type 2 diabetes. Does children who develop type 1 diabetes at the age of 13, 15 years have an ED at 30 or 40 or 50 years? No. Now studies have shown that erectile dysfunction is no longer due to blood sugar per se. It is actually due to abdominal obesity and metabolic syndrome, which totally destroys the endothelium. Basically understand, now we know that suppose a person is writing Viagra, a Viagra sildenafil 25 milligram, and even Jen Aushadhi has a tadalafil tablet 5 or 10 milligram which costs you 4 rupees. A tadalafil 10 milligram in Pradhanamantri Jen Aushadhi costs you 4 rupees. But if you write a person coming to you with ED at the age of 55 years, a tadalafil 10 milligram ചെയ്യുന്നിട്ട് പറയുക ഒരു ബന്ധപ്പെടുന്നതിന് ഒരു അരമണിക്കൂർ മുമ്പ് 2 ടാബ്ലറ്റ് വെച്ച് കഴിക്കൂ എന്ന് പറഞ്ഞാൽ 50% of the patients don't take it because they have read somewhere in the newspaper, somewhere in some magazines that all these drugs can cause some harm to the body, especially they are more suspicious whether something will occur to the heart. So ultimately we know heart is the common thing, and we know that 65% of the people above the age of 45 years presenting with organic ED. Erectile dysfunction is divided into two, psychogenic, organic. Massachusetts male aging study, don't look at the slides, concentrate on me only. Massachusetts male aging study have shown that only 10% of men coming to the OPD less than 45 years have organic ED. In which 25 വയസ്സുള്ള newly married husband and wife വന്നിട്ട് പറയുന്നു ഡോക്ടർ erectile dysfunction എന്ന് പറഞ്ഞാൽ 1 in 10 only have an organic ED, remaining 90% is a psychogenic ED. Among them most common is a premature ejaculation or lack of libido. The husband says that I see my wife, I am not getting any kick. I go for intercourse, I am having a premature ejaculation with 1 minute. So ultimately that is known as premature ejaculation or whatever is a psychogenic ED. Less than the age of 45 years, 10 to 90% of the ED is psychogenic ED. Suppose a guy above the age of 60 years and comes to the OPD and tell, doctor, I am having erectile dysfunction, that means that almost 60% is organic, because as your age increases, your organic pathology increases. So basically, psychogenic, organic, whenever any person above the age of 45 years come to you with complaints of erectile dysfunction, rather than just sitting and prescribing a sildenafil or a Viagra, a tadalafil, a combination with depoxytin for premature ejaculation, loosely. No, before that, at least ask a history, check the testosterone, check the remaining things, and now all the guidelines say that the biggest risk factor for ED is no longer diabetes, it is abdominal obesity or metabolic syndrome with or without diabetes, which can cause endothelial dysfunction. And previously during my MBBS days, I studied my MBBS MD both Radhakrishnan in Trivandrum Medical College, MBBS 93-99, MD 2003, DM Endocrine 2003-2006, KEM Bombay. During that period even opened Harrison 15-16th edition, second volume, second chapter. The chapter was on impotency. Now you don't hear the word impotency per se, because as per the revised guidelines of NIH 1992, the term impotency is deleted from all the textbooks and the modified term of ED or SD, because addressing a guy as an impotent guy or a shandana and impotent, that itself is thought to be a great insult to manhood. If we transgender or disorders of sexual differentiation, we careful to be impotent guy, divorce, impotent bicycle, that itself, a guy can have a PMA, a guy can have a coronary artery disease with an endothelial dysfunction, a guy can have a prostatitis, a young guy can have an accident and an ED. You can't address him as a guy with an impotence as an insult too. So that is why the modified term of ED or sexual dysfunction. And we know Rubin Shah, who is Rubin Shah, just like we saw Sri Thril Mellithan Sarna Balvan, for any urologist, Rubin Shah, when you go for any urology conference, he is considered as the father of Indian andrology, because Shah metallic process. We know whenever a person person comes with an refractory erectile dysfunction. Suppose a guy at the age of 40 years have a coronary arteries with type 2 diabetes, he is on a sildenafil citrate, but he is not responding because of total endothelial dysfunction, or because of sorbitrate therapy, he is not able to take a sildenafil citrate or tadalafil regularly. Ultimately, he has to go for a penile prosthesis, because the treatment for erectile dysfunction, that's why I told you, I have only 20 minutes, don't look at the slides, just understand what is there in Harrison. So suppose a guy needs to have a frequent intercourse. A guy at the age of 75 years can come and say, doctor, my wife is 65, we need to have an intercourse once in a month or once in 2 months. Okay, you can go for an intracavernosal alprostadil injection or a micronized urethral, whatever alprostadil given through the urethra, or you can take a tadalafil in a dose of 20, have an erection. Suppose you are a young guy, 40 years, your wife is 35 years, or a guy sometimes in Gulf, 15 days, I got here 15 days for 12 years, I'm in UAE. There are also some elderly people, 50, 60 years, they marry young ladies, Moroccan, 20, 25 years, and come to the OPD. The wife demands sex daily or once in 2 days. You can't take a sildenafil citrate or tadalafil every day, or go for a cavernosal injection of an alprostadil or a phentolamine, papaverine, and go for a sexual intercourse. There you have only one thing, that is nothing but a penile process. So that is why sex, it never ends. You can have sex at 45, you can have sex at 55, 80, 95. The oldest person which I have sent for a penile process, one of the celebrity, whatever film star here, is 83 years, because at the age of 83 years also his libido is so high, but his penile erection is not good. So ultimately at the age of 80, 83 you can have sex. Whereas here above the age of 45 years, how many of the guys having an erectile dysfunction? Erectile dysfunction never means a total lack of erection. What's the Harrison definition of erectile dysfunction? It's an inability to attain and or to maintain an erection of sufficient rigidity and duration so as to get a satisfactory sexual intercourse. That is, a person is not able to attain erection, that is ED. A person is able to attain erection, not able to maintain that erection, that is also ED. A person is able to attain erection, maintain erection, but not of a sufficient rigidity that his partner wants for a sexual intercourse, that is also ED. A person is able to attain erection, maintain the erection, that too of the sufficient rigidity, but his partner tells that I didn't get any satisfaction at all, that is also ED. So ED never means that a total lack of erection, it is somewhere in the process. And a person who comes and tells, doctor, last week I had a proper intercourse, today my sex is not working, that is a psychogenic ED, because psychogenic ED can occur in one day. Rapid loss of erection occurs in two conditions, either a spinal cord injury or a psychogenic ED. Whereas diabetes, hypertension, hyperlipidemia, your smoking, alcohol, everything was a slow decrease in the endothelial function. So your history itself is the biggest clue. And what about the relation between obesity? That's why I'll be touching. Whatever my time finishes in 15 minutes, I'll be finishing. But just understand the concept, whatever Robbie, everyone is telling. So basically understand what is the relation between metabolic syndrome and erection. I'll come to that. So what is metabolic syndrome? We know that 90% of the diabetes that you see in your OPD is type 2 diabetes and 10% is type 1 diabetes. Open Harrison used to say, even now 90% of the type 2 diabetes people have a BMI more than 30. What does Indian guidelines say? Up to 50% of so-called Indian adults coming to the OPD have a BMI between 23 to 30, and many times we see morbidly obese ladies coming to the OPD. OPD you think that they'll be coming for evaluation of HbA1c. You check the HbA1c comes to be 5.5. They'll be showing a TSH of 5.5 or 6, thinking that subclinical hypothyroidism is causing weight gain. We know that subclinical hypothyroidism, just like pre-diabetes. A guy with pre-diabetes comes and, doctor, I'm in thirst, I'm urinating 5 liters per day. Either it's a psychogenic primary polydipsia or whatever absurd history is telling. Just like that, people come with subclinical hypothyroidism causing weight gain. Hypothyroidism itself in the most severest variety cause a weight gain of 1.5 to 2 kg due to mixed edema. Subclinical hypothyroidism never ever cause a weight gain. So it is actually weight gain which causes subclinical hypothyroidism to compensate for the leptin resistance. So basically understand, 90% of Indian adults doesn't have that much BMI more than 30. 50% of Indian type 2 diabetes have a BMI between 23 to 30. That is known as, Rajesh was asking, so that is known as a thin obese Asian Indian phenotype. To understand the thin obese Asian Indian phenotype, think of a person like me. My abdominal obesity is 95 centimeter. My age is about 45. Take a US citizen with the same age abdominal obesity as that of me. Take a CT scan abdominal L4, L5 level of me as well as the US citizen. That's an Indian, age 45 vayassu kazhinju, and adivarna vyasam 90 centimeter. Take a US citizen by my side, the same abdominal gut 95 centimeter. You take a CT scan abdominal L4, L5 level of me as well as the US citizen. Indian with the same abdominal gut is thought to have 3 to 5 times much higher visceral or intra-abdominal fat mass compared to the Western person. Nammalalle MBBS nariyan 2 types of fat, which Ashen sir was asking. Subcutaneous fat behind our skin, visceral fat in and around omentum. Subcutaneous fat is an inert fat which just drains to the peripheral capillaries, whereas visceral adipocyte is thought to be highly metabolically active. So tolid adipocyte fat is an inert fat that has no contribution to the insulin resistance, whereas visceral adipocyte, nammal autopsy cheyunu, alle kodiyo panniyo kandikkunnu kodallu chuttu nokkum manya fat kana, that is known as visceral fat. So visceral adipocyte is highly metabolically active. inactive. So triglyceride stored in the visceral adipocytes gets easily broken down to glycerol and free fatty acids, and this free fatty acids drain directly via portal circulation to the liver, causing hepatic insulin resistance. This explains why liposuction, which is a cosmetic surgery to reduce your body weight, never controls your HbA1c, whereas a bariatric surgery, either a banding or bypass, which reduces your visceral fat, is known as a metabolic surgery. It causes remission or probably a cure of diabetes in some people. So fat wherever is fat, but it is the abdomen fat, especially visceral fat, that's the biggest risk factor for insulin resistance. And when we all used to study for MBBS MD, there is an MCQ question, which gland is known as the largest endocrine gland in the body? It was thought to be the thyroid gland. Now it is no longer the thyroid gland, just like Ronnie was telling, it is the adipose tissue, which was once considered a waste energy depot, that is now considered to be the largest endocrine gland in the body, because adipose tissue produces a host of hormone. So basically understand, thin, obese, Asian Indian phenotype. ഭയങ്കര പൊണ്ണത്തിലുള്ള പേഷ്യൻ്റ് വരുമ്പോൾ നമ്മളായിരിക്കും ഷുഗറും കൊളസ്ട്രോളും ലിവർ ഫംഗ്ഷനും യൂറിക് ആസിഡ് ഇൻസുലിൻ ലെവലും HSCRP നോക്കാം. തിരിച്ച് അനദർ പേഴ്സൺ സ്റ്റാൻഡിങ് ബൈ സൈഡ് വിത്ത് എ BMI 24 may be having high chance of metabolic parameter, because looking thin externally may not be an obese internally phenotype. So that is why now JAPI has published a data in January 2022 that 90% of so-called normal looking Indian adults above the age of 30 years do an ultrasound for anything, let it be for kidney stone, gallstone, or a polycystic or a female. 9 out of 10 females have a grade 1 to grade 2 fat liver disease. ഇപ്പോൾ അൾട്രാസൗണ്ട് അബ്ഡോമൻ എന്തിനു ചെയ്താലും ഫാറ്റ് ലിവർ ഡിസീസ് ഇല്ലാത്തൊരു എൻറ്റിറ്റി കാണാനേ പറ്റത്തില്ല. സോ ദാറ്റ് ഇറ്റ് സെൽഫ് ഷോസ് ദാറ്റ് അവർ വിസറൽ ഫാറ്റ് ഇസ് മച്ച് മോർ ഹയർ. ആൻഡ് കമ്മിങ് ടു ദ സെനാരിയോ ഓഫ് ഫാറ്റ് ലിവർ ഡിസീസ്, ഹൗ ഡു പീപ്പിൾ വിത്ത് ഫാറ്റ് liver disease die? Nowadays we see any patient with fat liver going to a gastroenterologist. Gastroenterologist doing HbA1c, anti-HCV, ferritin, ceruloplasmin, anti-LKM ആണ്. 5 പിക്ചർ ചെയ്തിട്ട് വിടുന്നു, ഒരു വൈറ്റമിനെയും സിലിബോണും സ്റ്റാർട്ട് ചെയ്തിട്ട് വിടുന്നു. So what's the concept of NASH? Invariably now studies have shown that 75% of NASH patients die of nothing but coronary artery disease. 20% of NASH patients die of other fat related cancer, maybe a CA breast, CA colon, CA endometrium, now recently particularly we know CA pancreas, CA esophagus, CA gallbladder. So 5% of patients with fat liver disease only die of a cryptogenic cirrhosis or a hepatocellular carcinoma. So fat liver just shows, suppose my wife at the age of 40 years after pregnancy, after showing fat liver, so my age is 46, I am still having a grade 2 fat liver, non-alcoholic. That means that my visceral fat is much more higher, my triglyceride level is higher, my HDL is low. The same atherosclerotic process is occurring in my cavernous artery, coronary artery, as well as carotid artery. So 75% chance that you have to do a TMD and you are dying of a coronary artery disease or other malignancy, not of a fat liver going to a cirrhosis. And what are the drug of choice of NASH now? Endocrine clinics of North America, gastro guidelines. First line therapy for NASH guidelines should be guidelines. So first line therapy, diet, exercise, weight loss reduces NASH by 31%. Metformin 850 mg BD reduces NASH by 58%. Now Americans of all the Europeans of study of liver, ASL, everything have shown that the drug of choice of NASH is nothing but pioglitazone in higher dose of 30 to 45 mg plus vitamin E 400 mg BD. SPM PAR we have studied the required dietary elements of vitamin E is 22 mg per day, but antioxidant property of vitamin E comes at a higher dose, 2 rupee 50 paisa Evion or Evit, but antioxidant property comes at a higher dose of 400 mg BD. So diet, exercise, weight loss reduces NASH by 31%. Metformin 58, pioglitazone higher dose, not 15, 30 to 45 mg 75%. Statin, fibrate, vitamin E or listat, because during our MBBS days what was the contraindication of statin? So namalella MBBS hypersensitivity reaction, pregnancy, lactation, SGOT, STPT more than 3 times the upper limit of normal. People used to do SGOT, STPT before statin, 8 weekly thereafter, and 6 monthly every 6 monthly thereafter. Now you know you no longer have to do SGOT, STPT before or after starting statin. You may do an HbA1c once in 6 months. Statins always reduces NASH by 20%, and that's the concept of metabolic syndrome, because invariably even our people, World Egg Day, that's enough. So basically October 14th was considered as the World Egg Day. So World Egg Day in the WHO organization ലോക മുട്ട ദിനം, നമ്മളെല്ലാം മുട്ട കഴിക്കുന്നവരെക്കാണ്. ബീഫ് മട്ടനും എത്ര കഴിച്ചവനാണെങ്കിലും മുട്ട. ഇന്ന് രാവിലെ ഞാൻ തോന്നുമ്പോൾ ഞാൻ ടാക്സി ഡ്രൈവറിൻ്റെ അടുത്ത് എഗ്ഗ് കഴിക്കാൻ കഴിച്ചു. ഞാൻ രാവിലെ എന്നപ്പോൾ ഇവിടെ കഴിക്കാനൊന്നുമില്ല, നാച്ചുറലി ഞാൻ ദോശയും ചിക്കൻ കറിയും മാത്രം കഴിച്ചു. എനിക്ക് ഇഷ്ടമുള്ള ഞാൻ കഴിച്ചില്ല, ഞാൻ ഇന്നലെ ജീവിച്ചിരിക്കുന്നത്. യു ഹാവ് ടു എൻജോയ്, ബട്ട് യു ഹാവ് ടു ടേക്ക് ദ ബെനിഫിറ്റ് ഓഫ് സ്റ്റാറ്റിൻ, സാർട്ടൻ, മെറ്റ്ഫോമിൻ, വാട്ടർ ഇറ്റ് ഈസ്. അപ്പോൾ അയാൾ മുട്ടക്കറി വാങ്ങിച്ചു വന്നിട്ട് മുട്ടയുടെ ഉണ്ണി മാറ്റി. ഞാൻ എന്താ ഉണ്ണി, അത് ഉണ്ണിക്കകത്ത് കൊളസ്ട്രോൾ ഡോക്ടർ എടുക്കത്തില്ല. ഇന്നലെ രാത്രി ഞാൻ എന്നോട് ബീഫ് ഫ്രൈ കഴിച്ചതേ ഉള്ളൂ. സ്മോൾ അടിക്കുമെന്ന് വെച്ചാൽ ആഴ്ച 3 ദിവസം സ്മോൾ അടിക്കും. ബിയർ അടിക്കുന്നുണ്ട് എല്ലാ ദിവസവും, കല്യാണം കഴിച്ചിട്ടില്ല, പക്ഷേ മുട്ടയുടെ ഉണ്ണി മാറ്റി. സോ പീപ്പിൾ ഹാവ് ദ കൺസെപ്റ്റ് ദാറ്റ് eating contributes to cholesterol. Now guidelines say that only 10% of the cholesterol that you measure in the blood is contributed by food. 85% of a cholesterol is a byproduct of your hyperactive liver. You cannot control your LDL cholesterol by your diet, but your blood sugar and triglyceride can be controlled by your diet. So that's why we say the spate of film stars who died of heart attack. You know, Puneet Rajkumar dying, Siddharth Shukla, the big boss star, Jimmy workout irikkunnu asarele kaman apparthote verunu Chiyan Vikram Punniyan Selvanella abhinachita angioplasty Kaveri kanjane bypass endu Tamil Nadu Vikram KK Menon Raju Srivastava, everyone running in treadmill having a heart failure dying. What's the common factor of all these people? All these people have a good BMI less than 30, they exercise properly, and all including Chiyan is a vegetarian. They never take non-veg diet. So how did these people have a higher chance of heart attack? Because all these people are not on statin, because all these vegetarian people, suppose OPD il oru payyan varunu avan parnu doctor beef mutton onnum കഴിക്കത്തില്ല മലയ്ക്ക് പോകാൻ വേണ്ടി വെറുതെ എടുക്കുക നമ്മുടെ കൊളസ്ട്രോൾ 130 ഒരു സ്റ്റാറ്റിൻ എടുത്തേക്കണം LDL 70 താഴണം പ്രീ ഡയബറ്റിക് അവൻ എടുത്തോയി പറഞ്ഞത് കൊളസ്ട്രോൾ മരുന്ന് വേണ്ട ഡോക്ടർ ഈയിടെയായിട്ട് എക്സസൈസ് ഇല്ല ബീഫ് മട്ടനും കഴിച്ചില്ല അതുകൊണ്ട് കൊളസ്ട്രോൾ മരുന്നിന് ആവശ്യം he thinks that his diet contributes to cholesterol. Diet never contributes to cholesterol. Diet contributes to your triglyceride. That's why now all the US diet recommendation says that the maximum reduction in the LDL cholesterol that can be attained by the most severest of the diet and exercise is only 30 milligram. Whereas your triglycerides, suppose ഒരു വ്യക്തി ഇന്ന് രാത്രി പോയി കായസി പോയി 2 മട്ടൻ ബിരിയാണി അടിക്കുന്നു 2 മട്ടൻ ലിവർ ഫ്രൈ 2 ബിയർ കഴിക്കുന്നു നാളെ രാവിലെ അവന് ഭയങ്കര അബ്ഡോമിനൽ പെയിൻ ട്രൈഗ്ലിസറൈഡ് 15,000 he develops an acute hypertriglycemic pancreatitis. അവനെ നിൽ ഓർലി വെക്കുന്നു MCT ഓയിൽ കൊടുക്കുന്നു അല്ലെ ഫ്ലൂയിഡ് നല്ലതായിട്ട് കൊടുക്കുന്നു 3 days and you check the triglyceride will come 15,000 to 5,000, adding a fibrate after 5 days it will come to less than 200, because triglyceride or hyperchylomicronemia can be controlled by your diet. Your LDL cannot be controlled by your diet. That's why all the guidelines say that statins at 40, that's a rule. Age more than 40, every person, especially pre-diabetic, need to take a statin and keep the LDL less than 70, whereas females are always protected by the mighty estrogen, men are never protected by testosterone. That is why now limited studies says that even men with androgenic alopecia have high testosterone DHT sensitivity, they itself have 30% higher chance of coronary artery disease. Suppose you ask me, Dr. Bobby, how many years have you been practicing? I finished MBBS, MD, DM, DM 2 okay, for 16 years. You ask me, Dr. Bobby, how many patients you see? I see maximum 25 patients, but high-end VIP chronic patients, my business, these people only come and see me, they can only see me, but ultimately you ask me, Dr. Bobby, have you ever heard even a single patient having a heart attack as a lady less than 50 years? In my total 16 years of practice, I may be seeing 25 medical college professors, maybe seeing 200 patients per day or more than that. I have never seen a single lady less than 50 years having a heart attack, but men fall off having heart attack. In the number batch, 2 people have died, or at least 10 people are having a stent in my 93 batch, more than 20 may be having, they may not be telling outside, because females are much more fatter with a BMI compared to men, but ultimately they are protected by estrogen, men are not protected by testosterone, and there is nothing known as a decreased sexual function in a female. Female may have a decreased libido or a frigidity, decreased vaginal lubrication, vulvovaginal candidiasis, anorgasmia, but the active partner for sex is always male, because ultimately male erection should be maintained for till the time that the female has an orgasm, or still she said that we have to stop sex, we don't want, because I am satisfied, till that time a male has to maintain his penis in an erect mode. For that his penile endothelium should be firing nitric oxide and nitric oxide like anything, but your erection is not occurring, so ultimately you are going for an erection failure. That's why I told you metabolic syndrome is closely related to nothing but erectile dysfunction. Now I will be touching in 10 minutes, I will be finishing. Now come to the point of ED. Definition I have told you, inability to attain and or to maintain erection of sufficient rigidity and duration so as to get a satisfactory session intercourse, not for you but for the partner. 80% of men attain satisfaction by masturbation, but females hardly feel anything, because females always need whatever orgasm, multiple orgasm may occur, may not occur. For that it is not the erection that is important, it is the ability to maintain the erection. One push-up edukkunno പോലെ 40 push-up ഒറ്റ കയ്യിൽ എടുക്കുന്നു 50 എടുക്കുന്നു, അത് എത്ര നമുക്ക് കപ്പാസിറ്റി ഉണ്ട് അത്ര മെയിൻറ്റെയിൻ ചെയ്യുന്നതാണ്. So how does the process of erection occur? We have studied in Ganong and Guyton. Penis is a soft tissue organ just like our finger, which gets converted to a rigid rod-like organ which is capable of penetrating any intact vagina during the process of erection. So MBBS penis is made up of 2 groups of vascular smooth muscles, a central midline corpora spongiosa which bulges to form the glans penis. On either side of it is a pair of corpora cavernosa which are the actual mediators of erection. So how does erection occur? Suppose a person is having libido, or a female may be thinking, or whatever, you are having the libido to have sex with. So what is corpora? It is vascular smooth muscles. So smooth muscles with endothelial lining. Just artery endothelial lining. whenever you have libido, the corporal cavernosal endothelium produces nitric oxide, so it causes vasodilatation. We know the most potent vasodilator in the body is nitric oxide, and the most potent vasoconstrictor in the body is endothelin 1 followed by angiotensin 2. So ultimately, a person is having libido, corporal cavernosal endothelium nalla fresh ആയിട്ടിരിക്കുക, ടക്ക് ടക്കാന്ന് nitric oxide ഉണ്ടാവും. Within 1 minute a female sound you are hearing, the moment you see the clip of a female, the moment you see an advertisement or whatever in the movie theater, you have a tight erection of your penis without even touching your penis. That means that your corporal cavernosal endothelium is so fresh that is firing like nitric oxide within a latency period of 5 to 10 seconds or maybe 30 seconds. But as your age increases, your endothelium gets fatigued. As your HbA1c increases, BP increases, cholesterol increases. As you smoke, the endothelium is getting destroyed. So the nitric oxide production capacity comes down. So appa aalkare palappadu doctor pandu penninte photo ketta manda madi alle wife vannu korchu samsaricha madi erection kittum. Ippam പക്ഷേ touch ചെയ്താലേ എനിക്ക് erection കിട്ടുന്നുള്ളൂ. So one is known as a reflexogenic erection, second is a neurogenic erection. Understand, neurogenic erection is thought causing erection. കൊച്ചിലെ നമ്മൾ ഇരിക്കുന്നു, ഒരു ഗ്ലോറി, നമ്മുടെയൊക്കെ കൊച്ചിലെ ക്രൗണിങ് ഗ്ലോറി ഒക്കെ പരസ്യമാണ് ആ പഴയ TV കാണുന്നത്. 4ാം ക്ലാസ് 5ാം ക്ലാസ് ഐ സ്റ്റഡിഡ് MBBS ട്രിവാൻഡ്രം ബട്ട് സ്കൂൾ ലയോള സ്കൂൾ. ആ സമയത്തെല്ലാം നമ്മളൊരു TV സോപ്പിൻ്റെ പരസ്യം കണ്ടിട്ട് മെനി പീപ്പിൾ അച്ഛനും അമ്മയും കൂടിയിരിക്കുന്നു, they have a tight erection without even touching within 1 second. So that means that endothelium is so fresh. But guys above 50-55 years, especially smoking, alcohol, dyslipidemia, where LDL is high, their endothelium is destroyed with whatever HbA1c, BP, cholesterol. So libido ഉണ്ട്, പക്ഷേ endothelium ഫയറിംഗ് ഇല്ല. ചിന്തിച്ച് പ്രയാസപ്പെട്ട ഒരു 5 മിനിറ്റ് തൊട്ട് തലോടിയാലേ ultimately it becomes erect, because it's the local reflex arc of pudendal nerve that you are stimulating. It is not your brain that is working. So thought causing an erection is neurogenic erection. Touch causing an erection, that means that your erectile capacity is almost gone. That is known as a reflexogenic erection. നമുക്കെല്ലാം അറിയാം, pudendal nerve is the nerve supplied to the penis. So S234, you are touching the pudendal nerve. From S234 it goes to the S234 segments. From there via nerve agent is to the parasympathetic nerve fibers. So it's not that. So whenever you have an erection capacity that is lost by thought and stimulated by touch, you think that your erection has come down. Be more cautious to preserve erection. So understand the second last sentence which I am telling. ED is no longer known as erectile dysfunction, it is known as endothelial dysfunction. A person after having adequate libido, understand each sentence, a person after having adequate libido in the absence of stress with a normal testosterone, ഒരു പേഴ്സണ് നല്ല ലിബിഡോ ഉണ്ട്, സെക്ഷൽ ഡ്രൈവ്, സ്ട്രെസ് ഒന്നുമില്ല, ടെസ്റ്റോസ്റ്ററോൺ 2 ഇഞ്ചക്ഷൻ എടുക്കുന്നത്, ഗുഡ് ബൂസ്റ്റിംഗ് ഓഫ് ടെസ്റ്റോസ്റ്ററോൺ, ബട്ട് സ്റ്റിൽ ഈസ് നോട്ട് ഏബിൾ ടു ഹാവ് എ penile erection. That shows that his corporal cavernosal endothelium is not able to produce adequate nitric oxide. The same process is occurring in his coronary outflow. That is the rule of 65. 65% of the people above 45 years having an organic ED have an underlying heart disease. Vice versa, 65% of the people who are having a heart disease have a history of ED 10 to 15 years prior to the onset of ED. And how does ED occur? Whenever you understand, it is just like a water tank. This concept it is not treatment of ED, it is prevention of ED that is important. 18 വയസ്സോട്ടെ, you know that US Center for Disease Control has told that age about 9 years, every children have to check the lipid profile. American Heart Association now has recommended that age about 20, lipid profile every 5 yearly for normal individual. Because if at all you are preventing an endothelial dysfunction right from the age of 8 years, 6 years or 15 years, that's the time you can prevent an ED by the age of 35, 45, because it is just like a water tank that is filled with dirt. This concept മാത്രമാണ് ഞാൻ ED പറ്റി മനസ്സിലാക്കാൻ. നമ്മളൊരു വീട് വെക്കുന്നു, അത് സപ്പോസ് ഞാനൊരു പുതിയ വീട് വെച്ചു, വീടിനകത്തൊരു വാട്ടർ ടാങ്ക് മേളിൽ കെട്ടി, പക്ഷേ ഞാൻ വീടിനകത്ത് താമസിക്കുന്നില്ല, ഒരു 6 മാസം കഴിഞ്ഞ് ഞാൻ വീടിനകത്ത് വന്നു, ഞാൻ പൈപ്പ് തുറന്നു, വെള്ളം വരുന്നുണ്ട്, പക്ഷേ വെള്ളമെല്ലാം തുരുമ്പിനകത്തും പായലിനകത്തോടെ ചീറ്റിയാണ് വരുന്നത്. അപ്പോൾ ഞാൻ എന്തൊടുക്കും, ഒരു കമ്പി എടുത്ത് 2 കുത്തുമ്പോൾ നല്ല ഫോഴ്സിൽ വെള്ളം വരും. അപ്പോൾ എനിക്കറിയാം ഈ വാട്ടർ ടാങ്കിനകത്ത് ഫുള്ള് ഡേർട്ട് കിടക്കുക, അതുകൊണ്ട് വെള്ളം കറക്റ്റായിട്ട് വരും. ദാറ്റ്സ് ദ സെയിം occurring in your body. Each gram of HbA1c above 6.5, each millimeter of mercury above 130, each milligram of LDL cholesterol above 60, each puff of cigarette you smoke, each snore you snore is first occluding the narrowest artery in the body, that is your cavernosal artery, which has a diameter of 1 to 2 millimeter. Your coronary artery has a diameter of 6.5. Whenever you take a statin to keep your LDL less than 70, whenever you take a sartan to keep your BP less than 130/80, when